I'm Elizabeth Wolf-Birchfield, and I'm an assistant professor of medical oncology and palliative medicine at the University of Kansas Cancer Center. The focus of this talk will be palliation of an unresectable kidney cancer mass using systemic therapy. Here are my disclosures. On its surface, the definition of an unresectable kidney cancer mass might seem pretty simple or clear-cut, but I would propose there are a couple of different definitions of this conceptually. The first one is really what most of us are going to think about when we're considering a mass that's unresectable. And that means that the tumor simply cannot be excised due to technical, anatomical, and feasibility issues. While I think the definition of this really depends on the surgeon, him or herself, and the volume of radical nephrectomies that they do per year, there are some pretty commonly agreed upon anatomical features that make a kidney mass unresectable. For right-sided kidney masses, it would be extensive liver invasion. For left-sided masses, it would be involvement of the celiac axis or the SMA. And finally, just having extensive retroperitoneal disease and really bulky disease just may make it technically unfeasible. The alternative definition that I want to put in your mind is that of a patient who cannot be offered an operation because of medical reasons. So this is typically going to be someone who's chronically critically ill, either due to their cancer or something else. And it means that surgical management is just not medically appropriate because of these comorbidities. Sometimes this population overlaps with the former. And while we're going to spend the bulk of this discussion on the former, as a palliative care physician, I would be remiss not to spend at least a little bit of time on the latter group. Logic would dictate that if someone has an unresectable kidney cancer, that cancer is therefore incurable. From an ethical perspective, when it comes to treatment decision-making, an incurable cancer can really be treated in a very similar or even identical fashion to a metastatic cancer. In some cases, alternative local therapies can be possible, something like embolization, although I think I might argue that isn't always the most palliative experience for the patient, but the focus of this talk is going to be on systemic treatments. So I do want to spend a brief minute talking about the definition of palliation. So while I think in some contexts the definition of palliation is quite clear-cut, this term is actually used with some variability historically and now. So historically, this term really meant relief of physical suffering, and in more modern times, this has also been adapted to add that we're managing physical suffering without being able to make the underlying cause better. However, I think we can all agree that often when we're discussing palliative systemic therapies, we sometimes are using that term to mean helping control the cancer for a time, helping a patient live longer without being able to cure them. Generally speaking, if we're able to achieve good symptom control with palliative treatments, life expectancy will be longer than if we hadn't attempted those treatments. However, I think we all have also witnessed that prolonging life and controlling the cancer is usually associated with some treatment burden. And so therefore, that's part of what makes the term palliative a little bit murky. When we're talking about using systemic therapy to treat a cancer that we otherwise can't cure or manage, it's really essential for us as clinicians to be finding a place of alignment about what we're really talking about with our patients and their loved ones. So in thinking about treatment, I think if palliation is the goal, logic would dictate that we might want to prioritize treatments with the highest overall response rates. So, however, in spite of that being the goal of a palliative systemic therapy, if we're really talking about neoadjuvant therapy, I think data is increasingly showing that overall response rate isn't the end-all be-all, and some wonderful and likely to be high-impact clinical trials that are ongoing now are going to help us further refine what other endpoints we need to be striving for in the context of neoadjuvant therapy. However, in speaking about palliative treatments, if we're talking about using overall response rate to help us prioritize our choice, I think, are overall response rates all made equal? Probably not. Are combination therapies really worth the extra overall toxicity? And then, are there specific risks that we need to be considering that are specific to combination therapies or certain components of a combination? So from recent times, prior to the current therapeutic paradigm that we're using for metastatic disease, small but high quality and robust clinical trials did investigate the use of tyrosine kinase inhibitors to downstage locally advanced kidney cancers in hopes of being able to help patients undergo definitive surgery. So these studies have shown that we can achieve radiographic partial responses to neoadjuvant tyrosine kinase inhibitors. So generally, the median overall sort of tumor reduction, it ranges from 17 to 28% in up to 45% of patients. It can facilitate nephron sparing surgery, and however, it does seem to be limited in the ability to downstage tumor thrombus. We also learned from this work that tyrosine kinase inhibitors, when used preoperatively, really do seem safe as long as we're holding them in a time frame proportionate to their half-life. It does not really seem to significantly elevate operative risk or perioperative complication rate. In the more modern era of our current treatment paradigms, we have seen that immune checkpoint inhibitor combination therapies do have higher overall response rates compared to tyrosine kinase inhibitors alone when looking at patients who have metastatic disease. Some really wonderful and high impact work that has changed practice have demonstrated that overall response rates seem to vary between 48% to 59% with these combinations that either include two checkpoint inhibitors or a tyrosine kinase inhibitor and a checkpoint inhibitor. The question remains, though, can we really extrapolate overall response of metastatic disease to what we see in the primary tumor? I think the jury is really still out there, and I think we will see more to come from that, probably in the context of neoadjuvant trials. However, we have seen some data from the combination of axitinib and avelumab that shows that 39% of patients do experience a tumor shrinkage of at least 30% when they receive this combination. So that gives us a little bit of insight there. A lot of questions, however, about whether this approach seems to be as safe as using tyrosine kinase inhibitors up front for patients with unresectable kidney masses. Specifically, there have been some recent reports that have raised questions about whether using immune checkpoint inhibitors prior to surgery really increases surgical morbidity, complication rate, and other factors because of a significant desmoplastic reaction in the primary tumor and surrounding tissue. There are two primary series that have demonstrated this, and they seem to have a little bit of conflicting data. One showed that up to 81% of surgeons noted that performing radical nephrectomies on patients who had preoperative immune checkpoint inhibitor therapy increased the operative difficulty. There also did seem to be longer operative time, greater operative blood loss, and a longer hospital length of stay of 7 days. However, another series really didn't find these to be true. They had what was typical operative time, blood loss, and hospital length of stay for radical nephrectomies for these locally advanced cancers. One factor that seems to be explanatory is that the duration of immune checkpoint inhibitor therapy may be part of what's responsible for increasing desmoplastic reactions. In the first series that I mentioned, the median time of immune checkpoint inhibitor therapy prior to surgery was 10 months, whereas in the second series, the median number of cycles was 1.5. So I think that may be something that helps, that can add risk depending on the length of time that patients receive it. Of note is that in the second series, 3 of 10 patients did have more than 20 cycles of immune checkpoint inhibitor therapy. So again, I think that we don't know the whole picture, more is coming, but this is one plausible explanation. Given that this data is conflicting, we really need to find ways to assess surgical complexity and complication rate in patients who do get upfront checkpoint inhibitor therapies. I think Much of that is going to come from neoadjuvant trials. And again, we're not talking about exactly neoadjuvant therapy here, we're talking about palliation. So we know there's more to come. We think that we're going to learn a lot from neoadjuvant trials that will clarify best practices, and not just in terms of overall response rate in the primary tumor, but sort of prognostic implications of pathologic and radiographic responses and predictive biomarkers. Where we are currently, based on the data, I would propose that it would still be appropriate to prioritize therapies with highest overall response rate if the goal is palliation. So that being said, I do think that an immune checkpoint inhibitor plus tyrosine kinase combination could be very appropriate, knowing that surgical consolidation may be made more difficult by choosing this paradigm, but given that the goal is symptom relief, I think that these combinations would probably be reasonable to prioritize. That being said, I think expectation management in this situation is really, really essential. I think we all know that if with the right treatment, cancer-related symptoms should get better, but I think it's essential for us to give patients a very grounded framework for them to be considering their symptoms and what we expect to happen with them as they get this treatment. We all know that with treatment, cancer-related symptoms should get better. That's what we're hoping for, and that's the whole grounding principle of palliative systemic therapy. And so what we do see, though, is that treatment-related symptoms add to that. Now, while we know that if a patient starts here, what we're hoping to achieve is that they're going to end up with lower symptoms down here, I think for patients who are receiving it, they often go from their starting place to here, and that can be a little bit panic-inducing and really lead people to have existential distress. Because if we know that the goal of treatment is to improve their symptoms from their primary kidney cancer, and they end up having stagnated symptoms or symptoms that either perhaps due to the addition of cancer-related symptoms, their overall symptom burden isn't better, that is a very scary thing for patients to experience, and I think we need to do our best at helping them understand what's to come and giving them expectations. So I would say tolerance for medical burden really exists on a spectrum, and patients' position on that spectrum typically depends on the range of possible outcomes and the potential for benefit. So typically, treatment-related symptom burden that someone might experience is going to be acceptable when the payout and their potential for benefit is greater. That being said, it's not always so simple. There are many patients really do exist on a spectrum. I think the way I would depict someone who's willing to go through more in order to pursue better longer-term cancer control, longevity, and even more robust palliation of their mass is going to, their trajectory is going to look like this. However, there are certainly patients who are willing to go through a lot regardless of the potential for benefit. I think when we think about, medical oncology treatment, this would be something like, someone who's willing to have a stem cell transplant for whatever cancer they have, because that's a very burdensome experience, and we know that the payout may not be that high in some cases. We've also probably all met patients who are not willing to go through much no matter how big the payout. I think in a lot of cases, this is extremely distressing to us as clinicians because we know that we have the potential to really help promote longevity, cancer control, and all of those outcomes with treatment that is lower on the spectrum in terms of burden. These are things that really we need to assess with our patients in order to know how to guide them and whether systemic therapy for palliation is appropriate for them. So one possible outcome of palliating an unresectable kidney mass could be surgical consolidation down the line, and that may be able to achieve robust and deep responses and long-term disease control. However, I would say that robust data about this is currently lacking, and so right now it's really difficult for us to even define the magnitude of benefit for our patients when we're having these medical decision-making conversations. I would recommend as a palliative care physician that when we're having these discussions, when things are so unclear, that we do talk about the potential for long-term disease control, if that's something we think may be possible, And well, that is an abstract concept, and that can be difficult for some patients, but I think that's really the best that we have. So I do want to spend a little bit of time talking about the medically inoperable patient. Specifically, patients who are too medically frail or too chronically critically ill to be offered definitive treatment for a kidney cancer, thereby making it unresectable. So if it's goal concordant with the patient's values, then systemic therapy will absolutely be the primary tool. So primary palliative care is really important in this situation, and all clinicians who will be watching this already do this, but I'm labeling it for you so that you know that's what you're doing. I think that palliative care best practices would include, shared decision making, probably using a best case, worst case model. Some people may do this implicitly, others may have read about this wonderful data, but some of you may not be familiar with this concept. The general concept that is part of this decision-making tool is that we have a patient who has two very different options, and talking about what the spectrum of outcomes could be for each option and what we think is most likely going to happen. This figure is tiny. I recognize that, but I think what we'd be talking about with palliative systemic therapy, the narrative we would share a patient, we would draw a line and say, this is the best case, this is the worst case. The best case scenario is that we improve your cancer pain and bleeding by these medicines, and we shrink your tumor enough that it can be removed surgically. I'd say the worst case scenario is that the treatment doesn't work, and therefore you go through the treatment-related symptoms without being able to benefit. And then drawing, this particular framework would result in sort of drawing a line, pointing to best case and worst case, and then drawing something like an X or an arrow about where we think they land. And I think that in this circumstance, that could be something like saying, while there are no guarantees that these treatments will work, we think that the middle of this line is where you would land, because we know that 60% of patients who receive these treatments have response, et cetera. So that, I think, is a best practice to consider. I think it's really important to, as we say in palliative care, cultivate prognostic awareness. A really simple way to do this is just to say, I'm worried statements. I'm worried that the treatment may make you feel sicker while we're trying to make your pain better. If you're not comfortable saying I'm worried, and some people really aren't, that's perfectly okay. You could even say your surgeon is worried that an operation isn't possible, or your medical team is worried that, or your family is worried that you may be sicker. In any case, this language is really meaningful to patients and goes a really long way to help cultivate their prognostic awareness, as well as help them to feel heard and validated. I think it's important to have a medical contingency plan about what will happen if they cannot tolerate systemic therapy, what will happen if they continue to have symptoms that are refractory. Would that be embolization? Would that be a change of systemic therapy? Would that be a transition to hospice? I do think that hospice informational visits are underutilized probably. However, in this setting, it can be a little tricky. We all know that treatment-related symptoms from both tyrosine kinase inhibitors and immune checkpoint inhibitors really do resolve quickly once we know them and address them. So a hospice informational visit is a perfect way to allow patients to learn about what hospice looks like, what the resources are, et cetera. However, I would caution against making a quick transition or pivot onto hospice if someone clearly has treatment-related symptoms that are making them feel sick, because those can get better quickly. And frankly, medical oncologists know more about managing those than some hospice physicians do, no matter how experienced and talented. So without, as I said, without knowing what the potential for benefit is, long-term outcomes are difficult to define. In conclusion, systemic therapies are very viable treatment paradigms to use when palliating a kidney mass that's unresectable. It's appropriate to prioritize treatments that have the highest overall response rate, and that would be my recommendation based on synthesis of the data. The other reason to do that is because knowing that longer periods of immune checkpoint inhibitor treatment may lead to greater degree of desmoplastic reaction that could make surgery more complicated, using treatments that have the highest overall response rate up front may mean that we achieve adequate relief of symptoms, but also in some patients who may have the potential to have consolidative surgery, trying to do these higher impact treatments first may mean that they can be on a shorter duration of these therapies prior to going to the operating room. Prospective data certainly are lacking about outcomes and operative risk, but generally these classes appear to be safe. And there are a few case series that demonstrate some variability in surgical complexity, but generally that these are medically and ethically appropriate to do. Expectation management, clear communication about the lack of certainty, and also symptoms that may be compounded by treatment-related symptoms, as well as engaging in shared decision-making are essential in order to really avoid decision regret and provide well-rounded, ethically and medically sound care for our patients who are in this very difficult situation. Thank you so much for your time and attention.